the work that I do is all focused really on substance use, infectious disease, mental health disorders, so essentially kind of all of those related conditions. I'm also part of the leadership of a NIDA-funded center that we have at Cornell. It's actually across a number of institutions, but it's housed at Cornell, and it's CHERISH. It's a long name, but essentially stands for Center for Health Economics of Research, substance use, essentially Center for Economics on all the stuff I just talked about. And so our goal is really to develop and disseminate health economic research on healthcare utilization, health outcomes, and health-related behaviors that inform substance use disorder treatment policy and HCV and HIV care people with substances. So we have a few different services that resources that I want to talk about quickly for anybody who's interested in. I'll kind of talk about how that relates. We have a consultation service that I direct. We also have some training opportunities and a resources page that's handy for anybody who wants to consider doing economic evaluation. The consultation service, which I direct, is really open to anybody who wants to incorporate an economic component into their study. And honestly, it doesn't have to be academia, but it is obviously a good resource if a student wants to do some kind of research in this area, or if you're trying to write a grant or anything like that. So there's really no right or wrong time to approach us. I mean, even if you just kind of want help thinking through something, it's there. And you basically get 6 free hours of consultation time. We'll do our best to line you up with whoever's, has the most relevant expertise to your question. And the grant allows us to essentially fund the 6 hours of the individual's time. And then after that, it's really kind of up to the two of you how you want to proceed. So oftentimes, you might pull them in on a paper or a grant, or whatever the case may be. I also wanted to talk, especially since we're at college, about training opportunities that I have within my team. So my team specifically is dedicated to researching determinants, prevention, and care of substance use and mental health disorders, as I mentioned, and most specifically alongside clinical trials. So we work essentially with the lead team from the very beginning. We design the economic piece of the study, decide kind of what instruments we want people to answer, and work with the team throughout. When we look at I'll kind of get into all this, we look at the cost of the program, and then we look at the cost offsets. So if the treatment's effective, maybe we see fewer, say, emergency department visits, inpatient stays, and maybe we see those offset even the additional cost of treatment and that kind of thing. But there's also, it's very important to look at effectiveness, so we do that as well. And we have studies going across a multitude of settings, jails and prisons and other criminal legal settings, primary care, emergency department, substance use specialty treatment centers, harm reduction centers, say syringe service exchanges, you name it. I have too many studies at this point. But we also do a lot of secondary analyses once the main kind of pieces of the trial, the main deliverables are done. So we look at determinants of treatment access, outcomes, misclassification, and of course negative externalities. And for those of you, if it's been a while since that econ or anything, negative externalities are essentially all the negative consequences that kind of, I just think of it as kind of a ripple effect, right, that goes out from substance use. We know it harms our friends, our family, our relatives, and society as a whole, really, which is really what drew me into this work. Like I said, I was interested in healthcare from a young age, but really growing up and watching family and friends kind of succumb to substance use or, choose to take their own lives, that kind of thing. That really, like I said, I wanted to be able to help some way. But at any rate, back to the options, or the virtual and hybrid options, because so many different studies and there's so many different things to do throughout the course of those studies, there's always opportunities for a student who wants to work in this area if they would want to work with us, and we could do that virtually. We could also do like a hybrid or some virtual, and maybe we could even bring them out to New York for a weekend or a week or something like that. So definitely something we could think through if anybody's interested. So, and also on our website, we have these tools and resources. So even if you're just curious or thinking about doing any kind of economic analysis, we have kind of recommended instruments and measures that we use. We have these budget impact tools that we create, and I'll show you one of those later to really kind of help estimate the cost of incorporating a new intervention or something like that into different settings. We also have learning modules, so if you're just curious about kind of how this stuff works, I mean, I'll talk about it. Of course, you're always welcome to reach out to me, but we also have these little videos and that are kind of nice little bite-sized pieces if you want to learn more about some of these different things on the website. So what I want to do is like I said, I want to talk about kind of how we can use this to improve native health, but I'm also going to give a background on economics, just kind of hopefully provide the appropriate context. Like I said, stop me at any time because we can always kind of skip over some things to get to other things if we start running out of time. But why do we need economic evaluation? If you talk to some clinicians and people like that, they might say, well, it's, we don't need it. If it works, it works. Well, unfortunately, that's kind of a naive position, right? Because what we know is that all decision makers, all stakeholders have limited resources, right? And so the purpose of an economic evaluation, it's not accounting, it's not finance. We really just kind of use money as a way to put everything kind of on the same scale so we can compare these benefits and these costs, if you will. But what I always say is the purpose of an economic evaluation is to inform real world decisions. Right? So how do we help these people that are in charge of the resources, how do we help them make the decision that's going to really improve the well-being of the population, right? Like I said, relative clinical effectiveness, especially when it comes to the policymakers and decision makers, it's not usually enough just to say this works better than this. And honestly, it really shouldn't be. If we think about it, one of the concerns is that if we don't look at both cost and effectiveness. If we're only looking at effectiveness and we say, all right, treatment B works better than treatment A, so let's just go with that down the road, right? Well, what if treatment B is only a little more effective, but it's substantially more expensive? Well, then what? You use all of your resources essentially to provide people with treatment B, but that goes pretty quickly. Now you've got this whole group of people over here that could have benefited from A, right, that no longer have access to it. And so it's really about, like I said, it's not about money, it's not about saving money, it's about kind of maximizing whatever your target is, like health, effectiveness, togetherness, whatever the case may be. And so that really is kind of, it's all about trade-offs in a sense, whether it's at the organizational, the clinical, the community, the societal level. If we make one decision, the idea is we're giving up something, right? And so we need to kind of weigh the costs and benefits of that in order to kind of maximize that satisfaction or that happiness. So like I said, when we talk about cost effectiveness or anything like that, so there's different types of economic evaluations that I'll go over briefly here in a second. But the important thing, as I mentioned before, is that we're talking about both cost and effectiveness. Obviously, we don't want to just go with cost because oftentimes you get what you pay for. If we just go with the cheapest thing, our community is going to be much worse off, right? And like I said, we don't necessarily want to just go with the more effective measure. And so efficiency, like as I mentioned, is really what allows us, this idea of efficiency, to treat or to improve the health of the largest number of people. And then the other piece that we do alongside of this is looking into the resources and the associated costs that are required to run an intervention. So not just to start it also, but then also to keep it running on a day-to-day basis so that we can hopefully make it sustainable if it works, right? And then, as I mentioned, we put together these budget impact sheets to hopefully allow kind of any individuals who are interested in starting that to help figure out kind of, well, what would we need in our particular setting? We've already got this and this, but we would still need these, and this is kind of what the cost would be. So the first thing, when we start a study, I always tell people that we need to think about is, what's the perspective? Like I said, we want to inform real-world decisions, but who's making those decisions? Who do we want to address? So it's obviously very important because that tells us when we're looking at the different things that may be affected, like I said, potential cost offsets or whatever we're talking about, we need to know what resources count, right? So if we're talking to, let's say, a health insurer, well, what are they interested in? Whether that's IHS or whether it's whoever, they're interested in the cost of the treatment, they're interested in what we see just in terms of healthcare costs and hopefully effectiveness downstream. But if we're talking to, let's say, policymakers, right, they're the ones that are controlling kind of more of the resources. So they may be in charge of both the healthcare resources, but also other resources for the community. So if, let's say, this treatment's more effective and we additionally see people as they start to improve, maybe fewer run-ins with, criminal legal activity, or just being able to kind of work and be better parents and brothers and sisters and all of those things, right? We want to be able to account for those. Those are also important things. So there's kind of this range of perspective, and we'll talk about it now. So if we look at the guidelines for economic evaluation, they essentially say, well, you should at least have these two, this healthcare perspective and the societal perspective. And the healthcare perspective, like I said, is really just focused, it's essentially that insurer's perspective. We're over a certain time frame, we're looking at all of the costs associated with healthcare resources, including the out-of-pocket costs that patients incur, right? Societal perspective is really more ideal in the sense that supposed to capture everything that could be affected. So all the criminal legal stuff that I talked about, the productivity, patient costs, not just like their out-of-pocket costs for medication, but also the time that it takes to get to and from treatment, right? The time it takes sitting in the clinic, the time, maybe if you need a caregiver to go with you or to watch your children or whatever the case may be, but it also accounts for their time. And so all of these things that really add up, right? And things that matter to society as a whole. Well, the problem potentially with the societal perspective is that, as you can imagine, we start talking about all these ripple effects. It can be very difficult to capture all of those, essentially impossible. So if you want to compare the economic value of this intervention to this intervention to this intervention, and you're trying to use a societal perspective, that gets pretty tough. You're not always comparing apples to apples. Whereas with this healthcare sector perspective, you are, right? It's fairly usually straightforward, and that stuff's much more accessible and can be compared. But now the other thing, like I said, is that we also can include any other perspective that we want. So if there's a particular decision maker that we want to target, we can figure out what resources are important to them. We can also look at that, and we can figure out what costs are relevant to them. So as far as just quickly like a rundown of what's included in these, as I talked about, healthcare sector, you can see talking about those intervention costs, of course, as well as any other direct medical care costs. Societal is where we really kind of try to pull in everything that we can that could be influenced. The other one that we include a lot, or I think some form of this, especially when we're talking about behavioral health, substance use, all those things, is a policymaker perspective. Because like I said, honestly, we start thinking about who really has the resources, has the money that we want to talk to in terms of we need to convince to get this intervention going, to keep it going, that kind of stuff, right? It's going to be them. And if they're just focused on the cost of the intervention, it's probably never going to get up and running, right? All they're going to see is it costs this much. But if we're able to show them that this works, if you keep it going, right, we will see cost offsets down the line. It may not be tomorrow, but it may be, soon. And not just that, but improved effectiveness. And so then all of a sudden they can start to kind of see the bigger picture and make a better case for it, right? So the different types of health economic studies, just to give you an idea, because I'm sure you're familiar with some of these and probably heard them. Cost analysis, very straightforward. You're essentially just looking at the cost of an intervention or whatever, right? That's it. It can also be kind of an economic burden study. So for example, I did a paper a couple years ago on just what is the cost of opioid use disorder to the United States in a given year, right? And then being able to look at that across different age groups, et cetera. But again, it can be informative in the sense that it helps draw attention to this issue, but it doesn't really help us make decisions. It doesn't really help us decide what should go where and what trade-offs we should make. And that's where the cost effectiveness, the cost utility, the cost benefit comes into play. So cost effectiveness and cost utility, for all intents and purposes, they're the same thing. Cost effectiveness, what we're doing is we're looking at the cost per unit increase in something. So maybe an additional year of life on average, or an additional day free of depression, or whatever the case may be, right? Whereas with cost utility, we're also incorporating some measure of health-related quality of life. So we're, just because we know like an intervention, just because it might extend life, it doesn't mean all those years are going to be good years, right? So what's that trade-off? We kind of try to account for that. So essentially weight those years by the value of them, if you will. And then cost benefit, basically the same thing, but instead of looking at a cost per unit of something, we're essentially assigning a dollar value to that unit. So maybe we're saying, well, let's agree that a year of good health is worth $200,000 or something, right? We could then put that up in the numerator and then just look at kind of the net cost or net benefit, right? As opposed to having like a cost per unit of something. So that'll make hopefully a little more sense here in a minute. So when we think about improving native health, I mean, it's really, I think, the ideal way to look at these things, right? A holistic approach to well-being. So we want to be able to design these culturally tailored interventions that are going to address wellness in this holistic sense. So the mind, body, emotion, spirit, and going to balance tradition and culture, language and community, and all of those things, right? Versus kind of a more Western approach where it's just more focused on controlling the disorder itself, right? And kind of this, oftentimes, this separation between the mind and the body. So we want to be able to account for cultural appropriateness, right? Maybe we want to integrate spiritual ceremonies, traditional healing practices with modern medicine, collaborate with local spiritual leaders and traditional healers. Cultural competence, we want to make sure providers, we educate them on the cultural nuances and specific needs of the community, and that we familiarize them with local customs, traditions, and values if they're not from here or from the community. Also, community engagement, right? Organize community events and workshops on health issues and services, encourage participation in planning and decision making, and integrate, let's say, traditional language into materials and services. And we want to incorporate it, we want to make a welcoming environment, ideally, right? So in the clinic, let's say, incorporate traditional Blackfoot art, cultural symbols into the facilities, design them with cultural sensitivity, including private spaces for traditional healing, and be able to kind of integrate all of these things, right? I'll get to that in a second. But so as I mentioned, one of the first things that we do when we're looking at any intervention is we want to make sure that we're capturing all the resources. It's not necessarily, for example, when we go in to talk to somebody who's starting an intervention, we don't really ask them about costs, believe it or not. What we ask them about are the resources and how they're used. Who do you need to make this work? How much of their time? So we don't even follow like the study protocol. The study might say, well, we're going to budget one full nurse for this intervention. But you go talk to them and you find out, well, actually we need more than one nurse. We actually had to pull in another nurse. Or, actually we didn't quite need a full-time nurse. Maybe we only needed half of one. And so it's important for us to be able to figure out kind of exactly what's needed and assign those costs so that we're able to provide that information to someone who is looking to start this up. And it's important, so like if we go back and think about some of these things, right? Oftentimes these are things that may not be accounted for, but yet they're critical to making the intervention work the way we want it to work, right? And if you want to, and this kind of gets to this point of accounting costs versus economic costs. And so accounting costs, if you're writing a check, if anybody writes checks still, those are the funds that you write checks for, right? These are direct costs to keep the facility open or what have you. The economic costs are also going to account for any kind of donated services, volunteer effort, those kind of things, because not everybody's going to have that. So maybe in your particular instance, you were able to get all the people to donate their time and resources and space and all of those things, which are critical to making it work. But maybe that's not always going to be the case, right? So if you really wanted to say convince someone with the money to pay for this intervention and make it work the way it's supposed to work, you need to be able to account for all of these things, right? And show them we may not always get this subsidized, nor should it be necessarily. Just because somebody is willing to donate their time doesn't mean that they always should, right? That may not be the best use of their time.
So do you have to get somebody to donate to the accounting costs and the economic costs, or how do you?
No, it's a good question. So what we do essentially, so if we go in, let's say they're starting a new intervention at the behavioral health clinic, we would go in and we would talk to them about, okay, well, who's kind of most familiar with this intervention and what it takes to make it run on a day-to-day basis. And we would just talk to them about what resources, supplies, and materials they need, and kind of how much of their time is required, both to get it started, but then also to keep it going. And even if, but we would also ask, well, what about meeting space? Or what about all these other things that, they may not think to tell us initially and just, oh, well, because that's donated. We just had this extra space. Well, that's great. That's great for you, but the next place that wants to do this, they may not have that space. They may need to rent a space. And so that's kind of what we're talking about with the economic costs is, and then we will assign values later on. So we'll use values that are either representative to that specific area or usually like nationally representative values, for trying to, depending on kind of who we're trying to target with that decision making. Does that make sense?
So does Cherish then fund
These studies?
Yeah.
Oh, that's a good question. So actually almost all of our studies are funded by NIH or NIDA, so investigators put in the proposal, then they test the intervention, and we're part of that. And so we look at, we go in and talk to the people doing the intervention and look at kind of what those costs are above what's usually going on. Like, what are they adding on? And we focus on that. So, and then Cherish provides a good infrastructure. So both to support other investigators doing this work, but then it also does help support our work as well. Like if it's not fully funded by the grant or whatever, if we kind of need extra resources to do the study. And so when we're looking at the different costs, basically this is, and this is also a QR code to the resources page that has a lot of this, but we use an instrument, something like this, to help us guide those discussions with the people doing the intervention. It's essentially just a big list of things you need to think about that would be needed for an intervention. Anything from, you can see how many clients do you see, who do you need to make the intervention go? Do you have contractors that you need to pull in, equipment, supplies, all those kind of things. And so we essentially tailor this to the intervention, to the setting, and then, like I said, it helps guide those questions. And for the most part, as I mentioned, we get those just by doing a site visit and learning as much as we can about the setting, the people, and kind of what's needed. And then we sit down and we kind of have these semi-structured interviews. And then we break the cost down to fixed, time-dependent, and variable. So fixed are those costs that are obviously very important to get started, right? So maybe you need a new machine or you need a new whatever, but you really only have to buy it once. Or maybe it's a training to get going, right? And you only really have to do that once. Well, the thing is, you don't necessarily want to count for that forever, because over time it becomes negligible if we're looking at an average cost, right? Because it doesn't keep going. Then time dependent and variable are the ones that we're always going to have to worry about as long as we're up and running. So time dependent, a good example of that would be, say, a lease, right? You need the space, before you can help anybody, and that doesn't matter. And once you pay for it, you're kind of stuck with it for, let's say, at least a month. Doesn't matter if 0 people come in or 1,000 people come in, right? So it's not really accounting, it's not really a function of the number of people. Whereas variable costs are the ones that you need. Those are the resources that you need for every patient, every person that comes in, right? That's the time of, let's say, the provider, that's the medication, that's the whatever supplies you need. And so you need, obviously, to know that going forward. And so essentially all this to say, we really try to focus on both the implementation phase so that people know, okay, well, to get going, we need all of this, including, and this accounts for planning meetings, all of those kind of things that are needed to get started. And then sustainment, which is really obviously what we're most concerned with. Once it gets up and running, what do we need to do to keep it running and keep it working as well as it does? And so these are budget impact tools. This is an example of one that we did for incorporating medications for opioid use into jails and prisons. And so this is the dashboard, but you can see how the costs are kind of split up by the different categories. And then down at the bottom, well, actually it's not under the cutoff, but we also break it down to a per patient basis. So what's this cost like per patient? Which is useful if you think about kind of how insurers reimburse and things like that, right? If they're gonna fund this intervention, they're gonna be doing it on like a per person basis.
That's for one person?
No, sorry, this is not for, that's what I'm saying, it got cut off for, it didn't make it onto the slide. But below that, there's usually a, right, that wouldn't be very sustainable.
I was like, oh my goodness.
We should be cured.
Right? So cost effectiveness, kind of what I want to probably talk about the most. And one of the things, hopefully, if you remember nothing else from this presentation, is what it means. You know, like how do you actually use the term cost effective? People use it, as you can see by this old article from '86. The term cost effective is rarely used correctly here surrounding almost anything related to money in healthcare. It doesn't mean cheap, and it doesn't mean cost saving. Okay, those are kind of their own things. So, I'll tell you what it does mean. When we think about adding a new intervention, so if we want to add, let's say, a new intervention to the behavioral health clinic or to, you know, wherever, the school or whatever the case may be, what we see when we're done with these studies is that very, very few interventions, despite what you might read in the grant proposal or whatever, save more than they cost. More often than not, you're doing more, you're paying more, even after we look at some of those offsets. Because hopefully, if you think about it, people are also getting more care that they need. They're now maybe going to their primary care physician more, or they're taking their medications and going to therapy more, that kind of thing. So even if they are going to the ED less or going to, you know, things like that less, more often than not, we still see on average the costs go up. So that's kind of where this cost effectiveness piece comes in. We're doing more, but we're paying more, but we're also getting, you know, better results. So is it worth it, right? Is it worth it to pay for those extra results? And that's kind of the question. So theoretically, cost effectiveness analysis, it's really straightforward. If we're looking at an intervention, let's say we've got our intervention group and our control group, right? We're looking at the average cost. We've got this whole group of participants in each arm, and we look at the costs, whatever perspective we're looking at, right? And we say, okay, at the end, on average, what's the cost difference? After we look at the cost of the intervention and all those other things, and also what's the difference in the effectiveness measure that we chose? And so we get this nice, you know, incremental cost effectiveness ratio that says, okay, well, if we want one extra year of perfect health, it's going to cost us $50,000 or $100,000 or whatever the case may be. Okay, but before we get there, I also want to talk about effectiveness. So how do we choose that, right? How do we choose a measure of effectiveness? Well, one, we need to know what the objective of the program is, right? We also need to know who our decision makers are and what's going to speak to them. You know, and that includes, is the measure generalizable enough to inform their resource allocation decisions? Because like I said, we can put pretty much anything in there, but in the end, if they see an extra, you know, a cost per, I don't know, additional day of whatever, does that speak to them? Is that going to move the needle? And then even, do we have enough information to determine whether the cost of adding that is a good value or not, so we can convince them? So if we go back to thinking about, say, these holistic approaches to improvement, well, ideally, then we would also have an effectiveness measure that addresses each component, and oftentimes that's missing from the literature. So if we think about what we usually see for economic evaluations, we often include measures pertaining to physical outcomes. So maybe if we're talking substance use, maybe it's days of use or frequency of use. We also often, or actually pretty much always, include a health-related quality of life instrument, which is multidimensional. So it really actually speaks to a number of these, and I'll show you an example here in a second. One of the ones that we often don't have a very good measure of, though, and we're trying to incorporate more, is say a measure of spiritual connectedness or belonging, right? And so if we think about this, the thing that kind of is a little, gets me, I guess, is we've got this great approach to this holistic measures and belonging and all of that, but at the same time, we think about how bad stigma can be, and honestly, stigma can be your biggest barrier. It can be your biggest barrier for people reaching out, for staying in treatment, those kind of things. So it's one of those things that we, like I said, it's very much a push to improve that. And that can be among providers, it can be among family members, community members, and so the more we can reduce that, that's also, I think, one of those important measures that can really actually have a profound impact on the effectiveness of any intervention. So in terms of an example of some clinical or physical measures of effectiveness, we might use, say, a substance-free day, a period of time free from substances. We'll usually move it up to a year because it aligns nicely with, we have a quality adjusted life here that I'll talk about here in a minute, which is a very common economic measure. It's also just kind of a good way to think about things budgetarily, et cetera, is on an annual basis. So usually it's some measure of time free from like the substance or depression or whatever intervention, whatever disorder you're trying to address. The advantages of these types of measures, they're very informative, they're usually pretty available, easy to understand for the most part. Disadvantages is they're not comparable across diseases and disorders. So for example, let's say we're trying to get the tribe to pay for this new opioid use intervention, right? But they've also got to make decisions about what else to fund when it comes to education and all these other things. So the question is, though, how do they decide what's a better use of the resources? Well, if we're looking at the cost per additional day free of opioids, that does nothing. We can't compare that in terms of like an additional, benefit of this educational intervention or this educational component, right? You can't really compare it. Or even if we're thinking within a healthcare system, do we put the money towards opioids? Do we put the money towards cancer, towards diabetes, whatever? But we got to have some kind of measure that would allow us to compare across those. So they have their advantages. They also have their disadvantages. And they don't always account for broad ranges of health outcomes that are associated with chronic conditions oftentimes. So that brings me to the health-related quality of life piece, like I said. So what we do is the individuals in the trial, they fill out this health-related quality of life instrument, and they do it at multiple time points throughout the study. And that allows us to essentially track their health-related quality of life, and is it improving over time. And again, it's important because it incorporates that quality of life component. The other nice thing is it is generalizable. So a quality, they kind of say, is a quality, meaning it doesn't matter if we're looking at an intervention for education, an intervention for opioids, an intervention for cancer, whatever the case may be. If we're looking at this additional year of quality health, right, or an additional year of perfect health, if you will, and this accounts for, I'll show you in a minute, physical, mental, all those things, right? Then that's something we can compare all across the board. We can say, well, this intervention will only cost us $50,000 to get an additional year of perfect health on average for the population. This one maybe is 150, maybe this one's 200, and that can help us decide where's the best place to put, those funds. So one example of a health-related quality of life instrument that we use is this Proper, and it's readily available at the NIH. And you can see it has all, how many, 7, 9 different domains, but depression, anxiety, fatigue, pain interference, pain intensity, physical function, sleep disturbance, as well as ability to participate in social roles and activities, so your ability to socialize. And so the nice thing is we can look at these individually. We can get a score for each one of those if we want to see just kind of how that's improving over time. But the other thing is we're able to condense it down to kind of this one score, right? That kind of gives us an overall idea of how the person's doing. And we call that a utility score, which basically just means satisfaction, happiness. And the idea with this is it ranges from 0 to 1. So 0 is a health state that represents death, essentially, right? 1 is a health state that represents perfect health, so a year of perfect health. Basically, you scored perfectly on all of these. And so, because I forgot to mention, each one of those, we ask questions, and it ranges from I'm having no problems in this area to I'm having extreme problems in this area, right? So if someone's having no problems all across the board, they would get 1. If someone's having kind of extreme problems across the board, they would either get a 0, or it is possible in some of these instruments, including this one, to get a range or to get a score below 0, meaning a health state that people would consider to be worse than death, which is interesting. We do see that occasionally. But essentially how that's created is, depending on their answers to each one of these questions within those domains, right, that combination creates like one health state. So someone's having severe problems with depression, severe problems with anxiety, but maybe no problems really with fatigue, no problems with pain. But you can see kind of how you score each one of those, and then the combination is kind of creates this health state. And and then the population essentially scores these, kind of the average population. That's a whole nother talk to get into, but at any rate, you can kind of see what they represent. So it's interesting. So if you think about maybe someone who's completely incapacitated, and maybe they're just, that's one kind of common example, I guess. But interestingly, you do see it even among some people with severe substance use disorders and that kind of thing. They're in this just health state that is a lot of people would consider to be worse than death. So I'm not going to, in the interest of time, really get much into this. But the idea is, so let's say these are our two arms, right? We've got our intervention and our control, and we're capturing, we're asking them about their health-related quality of life at each of these study time points. Well, you can see at the beginning, if we did a good job randomizing, they should be the same, right? They should be about the same health-related quality of life. But on average, remember, we're always talking on average. But as time progresses, if the intervention's working, we would hopefully see their health-related quality of life improving, and the other, the control, maybe not. Maybe it's either flattening out or even possibly declining over time. But what we really want to know is the difference between those two curves over that time period. And that will tell us the health, or the quality adjusted life years gained for the intervention compared to the control. And remember, so that's going to tell us essentially how many years of perfect health did the intervention arm get relative to the control arm. Whoops, did I go backwards? Now the easiest way to think about that, so remember we're going to look at the cost difference and the effectiveness difference, and we get that 1 unit. So we would get a cost per unit of effectiveness. So what's it cost to get 1 additional year of perfect health, let's say? Easiest way to think about that is within this cost effectiveness plane. So a couple of these are very straightforward. They're kind of like the duh quadrants. So if we find, and keep in mind we're always looking at intervention versus control, so it's always kind of in that order, let's say.
But if we find that the intervention costs more than the control arm, and actually on average people ended up being worse off, well, then yeah, no shit, we should get rid of that. We're not going to use that. If on the other hand we find, and this is where everybody would love to land, that the intervention actually saves money on average and improves health, well then that's a win-win, right? Of course we go with that, no more questions asked. Where we're really going to focus and where we land the vast majority of the time, as I mentioned, is up in quadrant 1. We're paying more, but we're getting more. So that's where the whole cost effectiveness piece comes in. Now the question is, for whoever that decision maker is, if they're willing to pay that price for an additional unit of health or an additional unit of, an additional year free of depression or an additional year free from opioids or whatever the case may be, then it's cost effective. If it's too expensive, they're not willing to pay for it, then it's not cost effective for them. And so as you can imagine, this varies across decision makers, right? This is gonna depend on who's kind of making these decisions. There are some kind of general guidelines. So it used to be like 50,000 per quality adjusted life year in the US. If it was below that, it was considered to be cost effective, kind of from a societal standpoint. But honestly, nobody even knows where the hell that came from. Like, you can dig in the literature, it's very arbitrary, it just kind of more or less came out of nowhere and stuck around for a long time. And even if you just adjust for inflation, today that would be over $157,000 per quality, right? Because that was from like 82. But more studies have kind of come along and looked at, well, what were we actually willing to pay for as a society and what did we find in terms of cost effectiveness? And they've decided, well, broadly, 100,000 to 200,000 is kind of where we should be looking. But again, that's going to depend, right? So if we want to be able to speak to a specific decision maker, whether that's a clinic or the tribe or the Medicaid or whoever the case may be, they're going to have their own willingness to pay measure. And that may be informed by their budget. It may be informed by their preferences. It's hard to say, but that's kind of what, ideally what we're able to talk to them about. This just quickly shows, in the end, kind of what we end up with when we're looking at the study. And so this is an example from a paper of mine from a couple years ago, but you can see, like, here is the cost of the intervention, the required detoxification, and then the study treatment. And these are two time periods. We looked at it over 24 weeks and 36 weeks. It's kind of hard to follow, but the idea what I wanted to show is that we look at these according to resource categories. So we can look and say specifically, did we see a cost offset in ED visits? Did we see a cost offset in inpatient stays or in whatever? We can look at those individually, and then we can also look at the total cost. And then we can as well look at our effectiveness measures both individually and as part of the ICER. So you can see that here we used qualities and we used abstinent years, so abstinent from opioids. Now, the best part of one of these studies, if you've ever sit down with one of these articles, you can kind of skip through a lot of the stuff. Go to the cost effectiveness acceptability curve. So depending on, again, the stakeholder, right? So whose decisions you're trying to inform once we've set that up, and we get that difference between the groups in terms of cost per additional year of perfect health, let's say, we run that kind of over and over again, using these non-parametric bootstrapping, it's called, but essentially kind of grabbing with replacement. So, you're taking the same size of the population that you looked at, but instead of just having the individuals in the study, you're kind of randomly sampling and then put them back. Because in the real world, there may be more than one person like me, more than one person like you, right? But in the study, maybe there was only one of us. So the point is, kind of gives us an idea across the population, and if we ran this 1,000 different times, what would we see on average? And so those blue lines are like those recommended guidelines I talked about in terms of cost effectiveness. And how this works then is we're able to look at any willingness to pay measure and say, well, what is the probability that we would actually consistently see this in the real world, right? This cost per unit of additional year of life for effectiveness measure. And so this is what's really, I think, beneficial to different stakeholders when we're talking about them. Like, look, if you're only willing to pay $100,000 to get an additional year of perfect health on average, the probability, let's say in this case, these are different time periods at 25 weeks, might only be 10%, right? But at $200,000, we're willing to pay that, there's a much better chance that that would work for us consistently, that we would consistently fall below that price point, right? And then similarly, as I mentioned, these change according to what stakeholder perspective we're looking at. So you'll have a different curve for insurers. You'll have a different curve for policymakers, society, whatever perspectives you've adopted. All right, so the last thing I really want to talk about, especially when we're talking about native health, so this is all like fantastic. If we're focused on one population, right? Let's say we're trying to speak to the council and decide kind of what's the best use of resources, and we're looking at these two options, but all among kind of like for the community, then that's fine. That's all we really need. But let's say now that we want to go to the state or some bigger entity, the federal government or whatever, and say, it's not enough, right? This is not working. We need more. Essentially, we need more money. How do we actually kind of make that argument, for these disparities and that kind of thing, right? So if we talk about cost-effectiveness analysis, what it's really ignoring, if we're looking at a broader population, is that these interventions can impact population groups differently. Right? So you may inadvertently end up widening health inequalities by favoring interventions that are benefiting populations that are kind of already advantaged, right? So there's this other method that's kind of new and whatever, but is very valuable, I think, for this kind of analysis, is this distributional cost effectiveness analysis. So what this looks at is how interventions affect different population subgroups. And it looks at both the cost effectiveness that we were just talking about, but as well as the intervention's impact on equity, fairness, those kind of things, right? So in that sense, it gives us a fuller picture of the social value of these interventions, and it helps us inform policymakers about decisions that balance efficiency with equity and not just focused on kind of treating everybody the same, right? Like they're all going to respond the same. So if we talk about factors that we know contribute to health disparities, I mean, there's obviously socioeconomic status, geographic isolation, we're talking about rural communities, historical trauma, stigma, etc., right? And as we talked about before, we want to design a holistic approach that's going to address all these and going to be appropriate for the community. That may be relatively expensive. It may cost more to reach, say, this community than Billings or Missoula or whatever, right? I mean, talking about kind of all these different things. And so we want to be able to account for that, and we shouldn't be punished for it either, right? So this distributional cost effectiveness analysis can account for those additional costs, and it does it by evaluating them alongside various forms of equity weighting, essentially, to analyze these trade-offs. So basically what that means is you can assign different weights to different population subgroups based on their health outcomes, based on the level of health inequality. And yeah, okay. So and basically what you end up with is we're kind of back to this same quadrant to keep things relatively straightforward. But what you'll notice is that it's slightly different. So in this case, we do kind of have to go back to that cost-benefit approach because we can't look at a whole range per unit of effectiveness. We would have to kind of settle on what we think a year of quality of life is worth, just for practical purposes, if nothing else. So let's say we decide it's worth $150,000. We can then get a net benefit, right? So we can say, okay, well, on average, the benefits associated with this intervention outweigh the costs, right? And we just kind of get this one figure. Then we will also have whatever our measure of health equity is, and we'll look at those two things combined. And of course, if we end up here, that's a win-win. that means when we're looking at this intervention across different groups, we find that not only is it cost effective for the different population subgroups, but it also is going to help improve equity, improve fairness, right? Versus say a win-lose where, yeah, it's cost effective possibly, but in the end it actually ends up kind of widening that equity gap, right? And then of course, lose, maybe it's not cost effective and harms equity. Well, in that case, that's kind of one of those duh ones. We want to get rid of that. Lose-win, it's cost ineffective but improves equity. So some of these, there may be, we're getting back to kind of this decision, right? So maybe it's not cost effective necessarily, but it does improve equity. Maybe we're still willing to pay a little bit because maybe it's not really all that cost ineffective, right? But we're willing to kind of pay for that additional equity. So that's kind of the idea, and really you can do a whole separate presentation just on that, which I think is really interesting also, but kind of gives you an overall approach. So I, of course, always forget business cards and stuff, but feel free to reach out to me, talk to me after. You can find my information's there. I can shoot you an email or whatever the case may be. But yeah, questions?
You said you might be starting a project here. Do you have any date or anything like that?
Not yet, but I've been speaking with the folks at Behavioral Health, and so we've got a couple things that we're working towards, and I'm always interested in speaking with others too. That any other ideas really. So hopefully, I'm working on writing something up now. So we're submitting a couple grants.
Well, I guess it'd be the results would have some interesting things to it, right? Maybe it might give us some idea on how to work with people here in an effective manner.
Absolutely, that is the hope.
Yeah, for sure.
Yeah, and just keep trying. I mean, we keep trying different things, but building on kind of what we already know works and doesn't work, and kind of always add pieces to it. So for example, we might find, let's say we get a mobile van or something that can kind of provide opioid use disorder treatment to some of the outlying communities, Hart Butte, Seville, even Bab, whatever, right? Something like that, kind of improve access. And maybe we find that works great, obviously relative to not having one. But then maybe we also incorporate, say, some peers in there, people who have lived experience and can kind of really make that connection. And we add that to the van, and maybe we find that works even better. So we kind of keep trying different things. And then what do we do if, the roads are really shitty and we can't get there? What are our backup options? Then, what do we do there? And so anyway, that's kind of what I was saying by the whack-a-mole thing. It's like, okay, we figured this out, but it's not sufficient. How do we make it even better? Because it's not reaching this group still, or we got them started, but now we can't keep them in treatment. How do we keep them engaged and keep them coming back? That kind of thing.
So how long would a study like that take in order for you to know what the health outcomes are of that program?
Oh, that's a great question. So usually these studies are if you get a kind of one of the bigger ones, they're about 5 years, but oftentimes you might do kind of a smaller pilot study before, so just to make sure it's going to work, so you kind of get everything organized and get things up and running. And that might be about 3 years, and then you can say, okay, well, look, this is working. We want to, do a bigger study now. And so that's always kind of one of the limitations, even say with the cost effectiveness piece, is, well, we observe these outcomes, we're looking at these outcomes over a certain time period. So usually we're following individuals for anywhere from 6 months is pretty short, 12 months is kind of ideal, 18 months is difficult but better. But again, we don't know. I mean, because people, hopefully if they improve, that continues to get better over time. And so it's kind of one of those things. We can also apply these models where we kind of try to predict how people kind of keep improving. And And there's a lot of those in the literature, but you always have to be a little careful with those because it really depends on what assumptions they made to build the model. Because oftentimes they're trying to take something that doesn't really exist, or there's not really any long-term data on it, and they're trying to, predict what's going to happen. Well, ideally, what we would do, because those models can be really beneficial, ideally what we do is we would have, let's say, that 5-year study, and we would take the outcomes from that, where we're able to really observe them, look at the variation around them, and kind of look at different sensitivity analyses. What if this ends up costing more or less or whatever, and then we would use those as inputs into the model, where it would be more informed, and we could do a kind of a better job of projecting outward. But sorry, did that answer the question? Okay.